There's even a name for it. There's a little literature on something called neurophobia, which is, really a legitimate thing that I think it's unreasonably and unfairly feared. Although, we all have our things that we feel comfortable with and not comfortable with. I'm afraid of kidneys, for example. I always found that much more complicated than the brain.
Welcome to the Specialty Café, the podcast that helps you, medical trainees, find your perfect specialty. My name is Cameron Wong, and I am a current fourth-year medical student at Queen's University. I'm here to do an episode on the replay of the primary specialties. The Specialty Café has done all of the primary specialties all throughout the early seasons, but now we're hoping to do some refreshed voices and revisit some of them to give an updated perspective. And I'm here with a very special guest, Dr. Chris Watling, who is a neurologist, as well as the current CEO of the Royal College. And I am really looking forward to chatting him about his specialty, neurology. Thanks for joining me, Dr. Watling.
Oh, it's a pleasure.
Before we start, do you think you'd be able to tell the audience a little bit about your career, your details?
So we're sitting in Halifax right now. I went to medical school here. And then after that, I was a resident at Western in London. And at the time, which dates me, I did a rotating internship, and then I did a year of internal medicine, and then I did neurology. I kind of had an inkling when I was in medical school that I was interested in neurology. I had the good fortune, I think, through a rotating internship of a bit of an opportunity to test drive that and to really kind of make sure that that was something that, that I could see myself doing for the long term. And luckily, I had a couple of really good reinforcing experiences that helped me to know that that was the right direction to go. So then I did my residency in neurology at Western. I did a fellowship in cancer pain management at MD Anderson in Houston in Texas. And then my first job was actually as a community neurologist in Sudbury before there was ever a medical school there. And so I was not a subspecialist neurologist at that point. I was a general neurologist, even some of the time a pediatric neurologist, because there wasn't anybody else who could do that.
Mm-hmm. Wow. So, and I guess one of the other things that I know about your career is that you've also served as the associate dean of the postgraduate medical education at Specialty School of Medicine.
Yeah.
And I've been really involved in medical education. So, I would say surprising as well that you've been able to have this experience as a community neurologist in a very a smaller community than London, Ontario.
Yeah.
Interesting.
Yeah, it was, there's a lot of sort of happenstance in a career that moves you in directions that you wouldn't have necessarily imagined. When I went back to London to work at Western, it was primarily because one of the things that I enjoyed most in Sudbury was, although there was no medical school at the time, there was a family medicine residency program that was centered there. It was affiliated with the University of Ottawa at the time. And so I had this opportunity to have residents spend anywhere from a day to a month with me in my office. And I just kind of recognized that those were the most energizing days for me when I got a chance to talk about what I was doing and to try to help other people develop skills that they would need. So my main reason to want to go to Western was actually to be able to do more teaching. And that's really as far as I'd thought it through. And I got a chance to be program director there for about 6 years, which was great. Terrific job. Anyone who's considering doing it, it's a great job. And then for about 9 years after that, I was associate dean for postgraduate medical education. And somewhere along the way, did graduate work and turned myself into a researcher in medical education, because really unexpectedly for me, that turned out to be something I felt really passionate about and really interested in. And so I kind of made a mid-career switch to really try to do more scholarly work in education.
What a neat evolution. When I think of academic medicine, I usually think about it in terms of people who have had mentors and extensive experience in academics all the way from undergrad, through to medical school, through to residency. And so it's a kind of continuum. And I don't really think of it immediately as something where you were a community neurologist and you had these interests that you developed while you were practicing, and then you tailored your career after that.
Yeah, to be honest, I don't I worry that we don't make enough space for that. Lots of people switch their career trajectory midway, sometimes more than once. And I think it's really important that we find ways of supporting that. There's a lot of pressure on residents, I think, especially if they're looking for academic careers, to do all of that training and bring all of those credentials and that skill to the table from day one. And I feel really fortunate that I've had the opportunity to have people who, I guess, believed in me enough that they were able to allow me to develop that on the job and to actually evolve my career, while I was already in a position. And it's great. It's allowed me to do things I wouldn't have imagined. I finished a PhD when I was 46. And when I had been a medical student, that would have been the furthest thing from my mind. So, but actually, I think I was just in a much different position in my life and my career. I was so, I actually had so much joy doing it, which I don't think I would have been able to find, 20 years earlier.
Right. Yeah, that's very, very cool. I really do want to touch on these unique aspects of your career. I think further towards the end of this episode, because I think it's just so rich to talk about. To also balance that on top of talking about neurology is a tough challenge, but we'll try to accomplish it. I guess just to complete the basic details of neurology, it's a 5-year residency. Is that right?
Yes, it's a 5-year training program. It's direct entry through CARMS. Pediatric neurology is a distinct training program from adult neurology, although adult neurologists have to learn enough about pediatrics that if they find themselves in a place like Sudbury, that they can do some of the basics. And the program integrates some elements of kind of general internal medicine type training, and some elements of disciplines that are related to neurology, neuropathology, pediatric neurology, and then a lot of time spent sort of developing I would say, the habits of mind that characterize the way that neurologists approach work.
I bring this up because I am going to be entering an internal medicine residency in July. Neurology used to be an internal medicine subspecialty a few years ago. Is that right?
I don't know that it's ever been a subspecialty specifically. When I did it, which was kind of a terrible system, you had to go and acquire at least a year of training in internal medicine. So it wasn't the same as a subspecialty where you'd do 3 years of core training and then go and do neurology. But there was a requirement that you had a year of internal medicine training. So when I did it, you had to go get that separately and then come to neurology. Now it really is, there is still some of that foundational medicine type training, but it's integrated into the training program.
That makes sense. Yeah, very cool. So to delve a little bit more into the finer details of neurology, can you describe the types of patients that you might see as a neurologist, recognizing that the scope is so broad?
Yeah. I'll draw on my experience as a general community neurologist, because I think that gives you a bit of a sense of the kinds of things that neurologists do. And of course, there are ways that people subspecialize and tend to focus on a particular area. But the general neurologist sees a lot of headaches. So you have to get really good at distinguishing among different headache types, and also being really committed to the long term in terms of the management, because it's often not really easy. That's the number one reason people would go and see a neurologist. Other common things that people would see would be epilepsy, neuromuscular problems, like neuropathies or muscle diseases, multiple sclerosis, relatively common. And then a big thing that often characterizes hospital neurology is stroke. So stroke, intracerebral hemorrhage, and the kinds of things that suddenly change somebody's life. And of course, neurology has changed really dramatically with stroke becoming an acute care emergency. And so neurologists also sort of there's that aspect of the work that's very much about chronic disease management over a long period of time. But stroke management has become, sort of in the moment, emergent, as fast as you can do it kind of care. So it runs that whole spectrum, right? I think the other area where, especially when I was in general practice in neurology, that I found was a common reason to involve me is this sort of consultation on hospitalized patients about broad questions like what's going on here. This person is acting strangely, or they're not waking up or recovering as we expected. What's actually happened to their brain? So there's a lot of neurology that's about explaining and also about predicting. Based on that explanation, what do you think is going to happen? Because it's so important that people can understand what may happen to someone neurologically in order to make some key decisions for them in terms of the kind of treatment support that they're going to have. So it's lots of stuff.
Right.
It's a broad field, but that's kind of a range of some of the things that neurologists might do.
Yeah, like not just the diagnosis and management of conditions, but then also like being a bit of a looking glass for your colleagues as well to clarify what you think might be going on, what you predict will happen, how that'll affect treatment down the line, and maybe affects like the patient's life, their function, and what they can do. Yeah.
I mean, one of the things that attracted me to neurology is the same thing that probably gets a lot of people interested in the first place. The diagnosis feels like a kind of a logic puzzle. And for people who like logic puzzles, that seems really engaging. But the truth is that the actual practice just begins at that diagnostic point. And then for many patients, we'll have years or even decades of post-diagnosis follow-up. And so the bulk of the work that you do is actually not that logic puzzle. It's the kind of the management of people who are coping with the ways in which neurologic conditions have changed their lives.
Mm-hmm. Wow. Yeah. You touch on an important concept there with like the diagnosis being a bit of a logic puzzle.
Yeah.
Neurology, among other specialties, it might, like as you alluded to with like the headache differential, might have a little bit more uncertainty to it as opposed to other specialties. Would you agree with that?
I would. I think, if you think about what are the characteristics that make somebody a good or at least a comfortable neurologist, one is an immense comfort with uncertainty. Every day, there are situations that the diagnosis is not clear, that nothing you do can actually make it perfectly clear, that it may not actually reveal itself for years. And yet sometimes decisions have to be made even in the face of that uncertainty. So coping with that uncertainty yourself, I think is one challenge, but also reflecting it in the way that you talk to patients and to their families. Because if you think that you're feeling ill at ease with the uncertainty, they're also likely sharing that, and helping people to manage that uncertainty is really key.
Yeah. And because of that, sounds like trust and like the ability to navigate like an emotional like diagnosis, getting to know like what a patient's like conception of like their illnesses and like what their priorities are is like a really key part of neurology.
Yeah.
It's like,
I think, in medical school in particular, there's a lot of emphasis on all those parts of the neurologic exam, and trying to learn that and remember that. But really, the most important thing that neurologists do, the most important tool they have is the tool of conversation. Both to understand the diagnosis, because most of that's in the history. It's not in those examination things. They're helpful and confirmatory, but most of it's in really enabling somebody to tell their story. And the other thing that is quite fascinating about neurology is I read somewhere it described that the symptoms are often outside the realm of normal human experience. And so people have a lot of trouble even describing them sometimes, and being able to pull a story out in a way that you can interpret and make sense of. And then I think the other tool is those difficult conversations over time about what does this mean for this person and for their family, and what's our role here in terms of how can we help with that.
exactly.
So that it's a conversational specialty, really.
Yeah. I'm glad to hear that like there's a humanizing aspect to a lot of neurology practice that there is out there, like with the conversation piece, with the history piece. I do agree with you. Neurology, at least like in my experience, in my pre-clerkship part of medical school, was a feared course. Like there's a lot of things to learn. There's a lot of different physical exam maneuvers. I think it is a complex specialty in the minds of like trainees of all levels, all the way from pre-clerkship to like even attendings as well, from what I know of. So
yeah, there's even a name for it. There's a little literature on something called neurophobia, which is, really a legitimate thing that I think it's unreasonably and unfairly feared. Although, we all have our things that we feel comfortable with and not comfortable with. I'm afraid of kidneys, for example. I always found that much more complicated than the brain.
So what would you say are like the aspects of neurology that make you most engaged with your work?
So I will give an answer that is probably not what you would hear from many neurologists. The last 10 years or so of my clinical career, I spent doing neuro-oncology. So virtually all of my patients had malignant brain tumors. And so the diagnostic part of it is not particularly challenging. It's you have a scan, you've had a biopsy, we know what you have. What I've always found engaging and rewarding was just the opportunity to be to be part of such a difficult journey for people, and to find opportunities here and there to do something that matters. It really is a remarkable privilege to be part of people experiencing the worst thing that they could have imagined happening, and to just stay with them through that. So rewarding.
Yeah.
But I don't know that that's necessarily what would engage everybody in neurology, but I always felt as though what I was doing was meaningful in that way. And it is a nice gift to come away from your workday feeling like you've done something meaningful.
Right. Yeah. I feel like many clinicians, I would say like maybe myself included, would like be super hesitant to enter like a sub field within like any field where there are poor outcomes, and like for example for malignant brain tumors. But I find it very admirable that like that's like what like gives you a lot of engagement with your work, and like hearing that like you feel it's such a privilege to be part of like someone's journey, especially when you're right, like it could be the worst thing that's ever happened to them. It's very powerful. Yeah.
Well, and you have to do some work to recognize that you are not responsible for the poor outcomes, but you are responsible for finding the things that you can do that make a difference. I think sometimes people feel like nobody even wants to talk with them, and share in some of the challenges that they're experiencing. So I think sometimes it's just makes a big difference to people to just have a straightforward conversation and to talk with them about the things that their family are afraid to talk with them about, or that their friends don't want to talk with them about. So it's about finding the opportunities to do something that's useful, that makes a difference.
Right. Yeah. I want to flip gears back to the like leadership experience that you've had now, because I do want to capture pieces of it. Specifically, you were Associate Dean of Postgraduate Medical Education at the Schulich School of Medicine for a while, as well as the Program Director for Neurology there as well. One question I wanted to ask is, you've probably been a part of many different residents' journeys all across the spectrum. You've seen them grow from R1s all the way to become staff attendings. Finding trends among like the residents you've met, what are some qualities that you've seen among residents that you feel like are predictive or like maybe associated with like being excellent clinicians?
Excellent clinicians or excellent neurologists specifically? I think there's some common things. It's funny, talking about residents' journeys. I just I'm part of some mentorship committees, and I just had a meeting with somebody that I've been involved in mentoring, who was about to go through the promotion process at their university. So had been, several years into an academic career now. And I remember interviewing her in CARMS. And so suddenly you see this fast forward to 15 years or so later and see all of what's been accomplished. Can you predict that in terms of, the qualities? I think a couple of things. A real commitment to communication, I think, characterizes good clinicians across the spectrum. Whether you are a neurologist or an orthopedic surgeon, you still have to sit with people who are having a difficult time, maybe who are experiencing the worst day of their life. And I think you have to be comfortable in that space and have to actually, to the extent that you can, have a calming effect through just being very clear and helping to walk people through things. And so when I see people who can do that, I feel pretty confident that they're going to be okay no matter what they choose to do, because I feel like that is the core of it, being able to connect with people, being able to develop relationships, brief or long lasting, with patients and with their families. Of course, you need to know your stuff. Of course, you need to kind of develop, a commitment to being careful and to being thorough, and all those things matter. But I think it's the relational part of things that, for me, is the real signal of somebody who's going to be okay and who's going to do a good job.
And that kind of stands out to me as an aspect of medicine that is, in a way, a bit time everlasting, regardless of how early you've practiced that in the 1700s versus if you're practicing in a century from now. Communication is really important to me as well.
Well, this conference AI's been everywhere, right?
True.
And one of the things I often think about is, what does AI mean for the future of physicians? What do we need human being physicians to do? And what can we do that AI maybe won't be able to do? Because I think it's true that there are a lot of aspects of our jobs that could at least be supplemented by AI. But the capacity to sit down and form a connection with people and to have them understand that there's another human being that's going to help them and help them to navigate things. I really kind of feel like we sort of have to double down on that skill development, because that's the key human thing we have.
Mm-hmm. It's true. In the same line as seeing residents through and seeing them become excellent clinicians, I do want to ask with this last question of the podcast, and I do wish I could speak with you for so much longer, because I think you just have so much to say. But in terms of advice, what advice would you give to kind of rising clinicians such as myself, me going into residency, but then also the other medical students who are listening to this podcast, maybe residents as well, and kind of about going through the medical training process?
I think the first piece of advice is to remember that you don't have to have it all figured out now. That it's not only okay, it's also possible to make changes in your career and your career trajectory. That might be within a specialty where you decide to develop skills in research or in leadership, or decide to really engage in teaching work, or decide to get involved in community advocacy. It might be something as dramatic as changing from one discipline to another. But I think one of the great things about all the different medical specialties is they actually give you a lot more room to take different paths than you might see initially. So don't be afraid to change your mind. Don't be afraid to remain open-minded to following different paths than you might have envisioned for yourself. And although it's good, I think it's good to plan a career, and it's good to, talk with people. You just can't plan it that tightly. Unexpected things will happen that will fundamentally change the direction of your life and your career. And I think you just have to be open to that, and to finding opportunities that speak to you and thinking, maybe I could do that. And then following it. And I think also well past residency, if you find something that you really like, don't be afraid to go back to being a learner, and to really, develop your skills in that area to enable you to actually, with some credibility, take on something new.
Mm-hmm. I see that as complementary advice to advice that I also got from Dr. Lasabakan, general surgeon who I interviewed yesterday at the conference.
Yeah.
He spoke about the importance of planning out a 30 to 40 year career plan, just because our career is short.
Yeah.
Maybe there's 20 to 25 years of practice, but with what you said, with just kind of remaining flexible to staying in tune with what your evolving priorities are, your evolving interests are, being able to have the flexibility to say, I want to go back to school to pursue something new and open up opportunities. I think they're complementary in a way.
They are.
Have an initial plan, but to also realize that you can do what you want with your career.
Yeah. I mean, you can't be aimless. And you don't want to change your mind every 6 months. That's hard on you, and it's hard on the people around you. But I think you do have to just keep an open mind about opportunities, and an open mind to a career that might actually take you in a different direction than you might have planned. Mine certainly has.
Wow. Yeah. Thank you so much for the chance to speak, Dr. Watling. I am really in awe of all the different experiences that you've been able to do. I don't know if I'll consider being a program director myself down the road. It's a bit hard to envision myself doing that, but I think seeing how your career has evolved in response to very natural developing interests, it allows me to see myself do it much more readily. So yeah, very inspiring.
Well, and the other thing is, don't be afraid to cold call and talk to people who do work that looks interesting to you that you could envision doing yourself, and just get some advice. People love to share advice. They love to talk about their careers, and so don't be afraid to do that.
And other people love to hear about them. So, but yeah. Well, thank you so much, Dr. Watling, for the chance to talk.
Thanks for the opportunity.
Of course, yeah. Thanks so much for tuning into this episode from the rewind of the primary specialties for the Specialty Café. Was really glad to get the chance to speak with Dr. Watling, a treasured guest on this podcast episode. And if you are a resident in a Royal College affiliated specialty, remember to join as a resident affiliate member because it is free. And we'll see you at the next episode. This is Cameron Wong with the Specialty Café. Thanks so much.